You're listening to the Cancer Assist podcast, hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Wherever you are in your experience, we're here to provide help and hope as you navigate cancer prevention, treatment, and care. Help when you really need it.
So welcome to the Cancer Assist podcast. I'm Dr. Bill Evans, your host, and today we're talking to Melissa Chadwick. And Melissa is a nurse working in the palliative care field in the area of Hamilton, and we're delighted to have her. But before I formally introduce her and ask her to tell us a little bit about herself, I just wanted to remind our listeners that the Cancer Assist podcast is brought to you by the Cancer Assistance Program here in Hamilton. And the Cancer Assistance Program provides a variety of free services to patients in need. Those services include free rides, equipment loans, nutritional and incontinence supplies, amongst a number of other supports for our cancer patients. And one of those supports is this podcast, which is made possible by generous donations from individuals in the Hamilton community. And we hope that by learning more about cancer, its causes, the current treatment approaches, and the supports that are available from various members of the healthcare community and volunteer organizations, that it will just make the challenge of dealing with cancer a bit easier. So, welcome, Melissa. I'm delighted to have you and to have an opportunity to talk about some of the things you know about palliative care, because I gather from our little pre-conversation your experience at multiple levels of dealing with palliative care issues, as well as some personal experiences that probably help shape your thinking and probably your drive to be involved in this particular area. So maybe you just tell a little bit about yourself to start off so our listeners can get a bit to know you, and then we'll dive into the palliative care topic.
Awesome. Thanks so much for having me here today. This is my first podcast, so I'm not too nervous, but it is just a conversation. So I've got this sort of microphone in my face, but that's okay. So I've been, my story sort of is that I feel like as a nurse, palliative care picked me. When I was young, I had a Wilms tumor, which is a childhood cancer, and I lost my left kidney and adrenal gland in 1979 to that, and had 18 months of chemotherapy and radiation at McMaster and then over at the Henderson, and very, very fortunately have survived that experience to be here today. And I have two healthy kids that are on their way to, I've got one at the University of Waterloo and one that's looking to go to Sheridan, and I just got married in September to my wife Tracy, so it's super awesome. And I really feel very fortunate. But I went to school in Toronto when I went to university. My dad was sick in the summer, and we still went away on our family vacation, and I actually had to drive him back from that. And he was a direct admit to Joseph Brant Hospital. He had a large softball-sized tumor in his sigmoid colon and metastatic disease, so where the disease had spread throughout his body. And that was really hard because I had just started nursing school. And my dad, unfortunately, passed away about 5 weeks later. But what that translated, I think, too, for me with the work that I do is that I'm honoring that legacy every day, sort of in and out. We had some good help and supports. It was a very, very unfortunate situation. My dad was young, 49, two kids, 16 and 19 kind of thing. And we weren't really prepared for what was going to happen. We had, like I said, good familial supports, really good supports at the hospital. My dad passed away in hospital, and they had a brochure that said, "My loved one is dying. What do I do? What do I expect?" And I use a version of that even now to this day to help people. But the more time I've spent working in palliative care, and I've worked at hospice, and I've done visiting nursing, and I've worked at home care, and I just find that more and more we're talking about being hopeful and talking about planning, I find, with folks now. So even in my own family, I sort of say to my mom, like, if you want to do this, I want to stick with you with that. But what does it look like if it's changing? Because we've got aging parents, or her husband has Parkinson's and things like that. So what are things kind of looking like? So again, sort of less talking about death and dying, but what are your goals? What do you want to look at? And so I find that things are changing a bit, and we're helping caregivers more also ask the questions back to their physicians and things like that. I also got to work at the Cancer Center, which was a really great experience. I was there for about 9 months, and that was sort of my break from death and dying a bit. But I found that when I was there, and I knew about Cancer Assistance Program at the time when it was in the little house, there were some great services and connections there. So I think we'll talk about some of those things in palliative care today with you here, Bill.
So as you say, really the palliative care chose you.
Yeah, absolutely.
And shaped your thinking. And those experiences, I think that's true for many who are drawn to work in the cancer field, is that they've had a personal experience and maybe it wasn't a good cancer experience and they want to be in the field so they can make it better. Or maybe they saw things that just sort of resonated with them in terms of the empathy and the caring, the supports of individuals that drew something out of them that was part of their innate being. But palliative care, I think there's a lot of misconceptions about it, and I really liked you to talk about that a bit because the term itself means to many people, I think, it's the end of life and maybe the very last bit of life.
Yeah.
And really, when you're trying to palliate somebody, you're trying to make the things they're experiencing better. And that could be at any point along the trajectory of an illness, be it cancer or heart disease or whatever. And we've somehow got to explode this idea that palliative care is just end-of-life activities, right?
Yeah. I blame sometimes television and movies for stuff like that, sort of that idea of what death is actually like. And so sometimes we have this idea that death occurs. I can remember watching a TV show and they sort of came out and said, I'm very sorry, there's nothing more we can do, and we sort of have this, I think, narrative in our head sometimes when we hear language like that. And where palliative care came from in the UK, Dame Cicely Saunders was sort of the grandmother of that movement. Mm-hmm. And the story I tell about her, whether I've got it right or not, but she was a social worker, I think, to begin with, or a nurse. I can't totally remember. And she was working in the hospital. And that's when you had the private rooms down at the end of the hallway, and that's where they put people to die. And there was nothing more we could do. And people would die sort of in a not very nice way. And this is like in the late 60s, 70s, very beginning of the 70s. And then she hurt herself, got reassigned. I don't know what happened. She ended up working at like a veterans hospital, and she found people were outside and they were eating what they wanted to, and they were getting their pain medication and symptom medication regularly every 4 hours, right? Which was how those medications work.
It's the military, after all.
Yeah, but people had much better experiences with symptoms. Their death was much more manageable than this sort of, we've done everything we can, down you go, and we close the door. So, and then she went back to medical school to become a physician, and so it was the birth mother, I think, of that movement. Then that came over to Canada in the 70s, and it's Dr. Belford Mount who started that and who actually coined the term, I believe, pallier, which means to cloak or to wrap around. And that's the thing. I think that when you hear the word palliative care, people think, oh, I'm not terminal, or they get almost taken aback or scared or things happen when they hear that. But it can be, you can have a palliative approach to your care for 10 years. You could have it for the whole time of that. From time of diagnosis is what they say. If we use that approach and talk to people about what their goals of care are, that they did a study, like I said, Harvard did a study, and when we do that approach from the get-go, and that could be oncology or cancer care, it could be cardiology, like heart stuff, it could be dementia, like gerontology, nephrology, or kidney folks, that people have less pain and symptom management issues, they have less anxiety and depression, and they live longer, on average about 3 months longer. But I think that in conversation is important to have up front, because what do people actually want? Because sometimes they'll just go along with what the medical system says or what their family thinks. And we have this idea that people give up. Sometimes I'd love to write a paper or unpack about that. I hear that, like, oh, so-and-so has given up or whatever. I'm like, death is natural. And so if someone has sort of checked all the things that they want to do on their list and they're moving towards the end of their story, it's not giving up. It's this nice, graceful sort of exit, like this, kind of thing. But we have these ideas sometimes about, oh, they're not fighting anymore. Like, again, militaristic kind of ideas. We're not fighting anymore. Or they're giving up and things like that, or fought a courageous battle. And that's not to diminish that, people with life-limiting illnesses aren't going through something or being resilient or suffering or those kinds of things, but it's not a loss. I want to go around and to the funeral homes and see who writes the obituary sometimes. Just change the language a little bit to bring it into 2024, because not to say those things aren't honest or authentic, but, you ever see like a really good obituary that's written in sort of a bit of a different way, and it's more of that about that person and their life and the celebration, not about how they died. Right. And I think that would make a difference, right? If we sort of had a more death positive view in society.
But we're a death avoidance culture for sure.
Absolutely.
And it's interesting when you ask patients, cancer patients anyway, what they most value when you're assessing like new drugs and things like that. They'll all say they want longer life and they want better quality life. And it's interesting just in what you were describing, what palliative care does. It not only makes the quality of life better by managing the symptoms much better, but it also extends life. And that's one of those surprises. You mentioned the Harvard study. There's other studies that have come out in lung cancer with palliative, sort of aggressive supportive care measures or palliative measures versus just the usual care, and a significant difference in survival. Mm-hmm. And I think that's a real surprise to the medical community. And it's like a lot of things that we know, but we don't really action very well, partly because we're busy. There's not enough time. There's so many patients. Treatment's got so complex, so we have to devote all of our energies into doing that. And some of these, quote, softer things kind of get pushed to the side or forgotten about. Mm-hmm. And we focus on sort of the technological and logistic aspects of care without thinking about how we're really, truly supporting people. And think about how can we optimally integrate supportive care, palliative care across the continuum. They really should interlock. And maybe the amount of palliative care, supportive care at the beginning of an illness, take lung cancer, is relatively modest because mm-hmm. maybe there isn't much shortness of breath, there's some cough, but no pain. But as the disease progresses, some of those symptoms might come to the fore. But if the palliative medicine supportive care physician or nurse or team was involved, they wouldn't have much to do at the beginning except establishing a relationship with the patient and with the family and getting to know them. And then as the trajectory goes along and they start developing more symptoms, they're better managed. And palliative medicine physicians, nurses, and teams are so much better at managing symptoms than are most oncologists. Not to denigrate what they do and how good or bad they are. They're really busy, and sometimes they just don't have enough attention to some of those details.
Yeah, and that's what I mean. Like sometimes it's those pieces that we want to, again, sort of walk alongside, and we want to build the capacity of the I know the oncologists are busy, and the oncologists are why I'm here, right? So I would never ever to speak out against oncology, but how do we almost walk two roads with oncology, right? So how do we say, yes, we want the advancements of science and new treatments and technology and better quality for patients and more quantity of life, but how do we sort of give them the skill set to say there's another treatment, there's first line, second line, third line, there's a clinical trial, right? And so how do we sort of say, you're laughing, that kind of thing, but those things are important because that's how we make advances. But how do we maybe say to the patients, what's your goal? What do you see for yourself? What you have, isn't curable, maybe, right? But it doesn't mean you're going to die in 3 days. That's what I think palliative care people, like when I said I was a palliative care nurse, I think people would almost want to hide from me a little bit. Or I will often say to friends and family, if they ask me a healthcare question, I'm like, you know what kind of nurse I am, you know what I do, right? And they kind of chuckle at me. And so, because we just become experts in different kinds of things. But if we could help, I think sometimes with the communication and the conversation, because I've experienced things where, a patient maybe didn't want to have more treatment and they stopped having treatment and they actually lived a lot longer because they responded to what they had. It just takes time. And I think sometimes that's the other thing too, is that we're always in a hurry and we want to do this and we want to do this and we want to know what's next. And then if we sometimes just pause. And I'm not a millennial. I always laugh and I always talk about millennials, so forgive me, millennials. But I say, we used to take a picture and we would have a roll of film and we would take it to the lab and then it would come back in a week and then they got 1 hour photo and that was really, really amazing, right? But now everything is so instantaneous. And when I'm looking, I did a lot of teaching in my role too in palliative care, teaching healthcare providers, PSWs, nurses, even physicians sometimes. And like, you don't have to be an expert right away or do things instantaneously, I think. And sometimes that pause is what we need just to see what happens.
And we're a very busy,
Yes.
fast-moving society. And I'm sure that also in the family constellation impacts the individual who's ill and the caregiver and the family around them, because they all got busy lives.
Mm-hmm.
And it's almost inconvenient that one of the members has got sick and maybe is deteriorating, could die in the near term. And how do you integrate those things?
Yeah.
And do you totally abandon what you're doing, which may be just too much for some people? Say, I've got a big job, it's important, I really enjoy my work, I can't give it up for dad, mom, or my sister, or whatever, because we're kind of ingrained at going so fast and doing things in a rapid way. So it makes it even more important, I guess, in our society that there be people and structures that can be used to kind of backfill for what it seems families no longer do. I know when I started in oncology, I was really impressed, particularly with the Italian families, and you go back into the 60s, 70s, and you had immigrant families who were so supportive of each other, and they always cared for their loved ones when they got sick with whatever. They just came around them, were supportive. And it wasn't my particular experience coming from a different ethnic group, but it seems to me that they had something really special by being so supportive of their members. And I'm afraid our culture is kind of losing that, and maybe even those who are third generation Italians aren't feeling so supportive of their loved ones as their parents and grandparents were. But, you know, different societies approach illness quite differently, and some are great at supporting, and some are almost like, I've had relatives say, Doc, why don't you just give the person a shot of morphine because they're going to die anyway.
Yeah.
That's the extreme. It doesn't happen very often, but it does tell you there are people who just see the illness of another human being as an inconvenience to their life as opposed to really an important person. So.
Yeah, like how do we kind of get to there, right? I mean, you look at the compassionate care benefits, right? So there's like the benefit that you can have you have to take a 2-week waiting period through, EI, unemployment, and then there's some paid time for people to have, and then they can be off of work. People could get replaced at work. Like, I mean, this is a number of years ago they introduced this benefit. It's probably one of the most underused benefits that we have out there. And that also what happens with that, in my experience, is that, yes, you need a doctor's note and things like that, but people tap into that benefit way too late. And again, so if I can say anything, palliative care early is better than palliative care late. Don't be afraid, I think, of that word and of the people doing that work, because we support people we would love to be meeting people when we talked about like a lung cancer patient much sooner in their journey, and then being there when they need us more towards the end of the journey, and that we get to follow along. And there's more legacy work that can be done. There's so many things we can do, psychosocial pieces of work that we can do, so many things that families and people can do. I have an app on my phone called We Croak. And it's, I think it's I don't know if we're allowed to talk about other things, but it gives you different thoughts and viewpoints about dying, because there's a culture, I think it's the Bhutan culture, that says if we think about death, it makes our life more meaningful. There's another book that's really good if people want to read. I don't know if you've read it before. A physician wrote it in the United States, Being Mortal. I don't know if you've read that book, or it's in your library at CAP maybe. I don't know. You have a library, I think, yeah. And he talks about his experiences and things like that, and also how people got into assisted living and safety and stuff like that as well. So it's just very interesting to say, I think that we kind of, again, sort of walk closer to the inevitable. Unfortunately, all of us are going to that place, 100% of us. But if we kind of can walk as a companion with it instead of being afraid of it, I think things would be a bit better.
I think we'll take a brief break right now and let people think about those things and go and write down Being Mortal. I've read that book. It's definitely recommended as well. And we'll be right back talking with Melissa Chadwick. And we're going to talk about the well-designed, perfect palliative care service network that you could have. Okay? We'll be right back.
We'd like to take a moment to thank our generous supporters. the Hutton Family Fund, and Banco Creative Studio, who make the Cancer Assist podcast possible. The Cancer Assistance Program is as busy as ever, providing essential support to patients and their families. We remain committed to providing free services for patients in our community, including transportation and equipment loans, personal care and comfort items, parking, and practical education. These services are made possible by the generosity of our donors through one-time gifts, monthly donations, third-party fundraising, corporate sponsorships, and volunteer opportunities. Visit cancerassist.ca to see how you can make a difference in the lives of cancer patients and their families.
We're back with Melissa Chadwick talking about palliative care, and just before the break we talked about what maybe would be sort of an ideal way that palliative care services were organized and delivered. And there's so many component parts, because there's a part that's sort of hospital-based, where you're integrating with those patients receiving care, be it cancer care or maybe cardiac failure or stroke care, integrating with those in a physical place called a hospital. But then there's so much more community-wide, and then there are hospices, facilities that people can go to truly at the end of their lives, but maybe for quite a long time. They may be there for months, but more commonly it's a shorter period of time. But they're very home-like environments, and maybe you seem to have worked in many of these places, so you're probably the ideal person to talk about them. And then what can bring it all together? How does it come together within a community where we're all so fast-paced, running around like?
I think what we're hoping to see is healthcare is being a little bit less siloed. And I would say so I have like a 25 plus year career in nursing, and mostly in home and community care, where before it was sort of like, you do this and we do that, like sort of more like a bento box or compartmentalized and sort of siloed, right? We know there's silos in care. And that one of the neat things I got to do this year, I got to go, kind of do it twice. In Hamilton, we had a Compassionate Communities event. And so it started off small with really just an idea. It was Esther Beatty, actually, who I worked with, who was a visiting nurse at VON for years. And then she worked over at Good Shepherd Emmanuel House in the hospice. And that she was bringing folks together. I was like, is this more like parish nursing? I wasn't sure, because we did it in a church, because churches just have spaces. And so we were just there, and there was, Bob Kemp, which is now the Kemp Care Network, Good Shepherd Emmanuel House, myself, Dr. Erin Gallagher, who's a palliative care physician and family physician, and McMaster associate physician. She does lots of different roles. Funeral homes were there. And so it was kind of small. They had like some lunch out, and people could come in and sort of see what services. Some of the agencies were there, like Bayshore Nursing was there. So it was sort of open up to anybody who worked in sort of the healthcare, palliative care business, if you will. And then that's where Erin met Esther. This is if I've got the story I've got it down. And then there were more people sort of saying, hey, well, my service does this, and they sort of did, I guess, of an environmental scan for being sort of most appropriate with words. And they had another event, and again, like nobody really owned it, I feel like. So yes, Dr. Gallagher did some of it, and Esther did some of it, and they made a small committee. One of my colleagues, Bob, he was on that, and they had Dr. Samantha Winemaker, who's been here before, on a panel, and Pamela Blackwood from McNally Hospice. So it's sort of that Greater Hamilton network of folks were there, and they had over 40 sort of tables or booths of different groups there. The CAP was there, I was there, funeral homes were there, the coroner was there, refugee, like Shelter Health, Newcomers was there, Margaret's Place Hospice was there, Camp Care Network was there, Emmanuel House was there, the paramedicine program was there, because that's one of the really neat things I think right now it's emerging, is that paramedics doing palliative care. I think that's a really good area where we've got a lot of capacity built in our communities with the paramedicine program. So all these folks are there. And then there's some folks there. I bought the best sympathy cards I've ever had. Like it said, I'm sorry, this sucks right now, kind of thing, or the holidays are hard and I'm sorry, kind of thing, like this, so they had some vendors there that you could purchase some things as well. They had a panel, and then they played music. And I had to teach a class in the middle of it, so I had to go back into one of the rooms with my colleagues, and because I did a lot of teaching of classes and stuff for palliative care. But it was really amazing. Like I think people got turned away because there wasn't enough parking, believe it or not. That was something they didn't foresee. I think they had up over 120 people attend, and they wanted to make sure they were hitting everywhere. So are they hitting home and community care? Are they hitting hospital? They kind of managed to get it to everybody. And if they wanted to be there, they were there. And it was just a really nice event for a couple hours where they had some structure with a panel and talk. They had someone who was, I think, more marginalized in their health care on the panel too. And so it was a really good event. Everyone, like, the day after was like, now what are we going to do? What are we going to do next? Let's have it at the Hamilton Convention Center. Let's make it bigger. Let's make it better, right? Like, let's invite more folks to that. But it's sort of like, I feel like it's like the new power, I think, a little bit, if you will. I know I sort of trashed the millennials, but I think what they bring to the table is that it's a collectivism. So it's not, the president and CEO of something has to say this is how it goes. It's a group working together with a common goal, and that's what they do. And that's almost like palliative care people, right? We are a group of people, interdisciplinary team, working together, trying to make the best of the time that you have left.
Now, thinking about our listeners out there, some of whom may be sitting in, I don't know, Australia, New Zealand, UK, what's the takeaway out of that? It's to create a very inclusive grouping of people who have a shared interest, but may have different skill sets and different capacity to bring resources into what we call broadly palliative care or supportive care for patients, right?
I think a lot of our model comes from the UK. So if we look at like an early identification, and early identification is like a document that we borrowed from the gold standards framework in the UK. So I think that also might sort of trickle over into Australia, New Zealand kind of thing, because we're sort of all the Commonwealth. We're kind of related, right? We are a bit behind, I would say, over here in North America, right? I've taught tons of students or worked with tons of people that work in long-term care, and they've been newcomers to Canada from the Philippines or different places in the world, and they're like, death is kind of funny here. Like, we embrace it more, or Latin America, right? Or Mexico countries, different countries are like, we're okay with this. We celebrate these kinds of things. So for different places, I think in Canada, a little bit we're awesome, but I think we're a little bit behind. But if you look at, like I said, like a gold standards framework, and if we look at illness trajectories, just to be technical, we sort of do have a crystal ball, and we sort of know how it's going to go. Not for everybody, but we kind of have an idea. We want to be hopeful. We want to give you the best treatment. We want to meet your goals of care, right? But we know that a person with, XYZ type of cancer or this stage of heart failure, we kind of know how it would look. Do you want to know that, right? I guess it's also inviting the person. Mm-hmm. And I think that's why the caregiver stuff is important too, right? Inviting them to say, hey, Dr. Evans, tell me about my stage 4 lung cancer. And it's not even about prognosticating or how long I have to live, but what's it going to be like? The doctor's the authority, I guess, a bit, right? Or the CEO is the authority or whatever, right? It's like inviting that person to ask you questions. One of the things we're working on right now is something called serious illness conversations. And as a person who's done palliative care for most of their career, I had this training I did online. And I found it incredibly hard because sometimes when someone's at end of life, we've waited too long and we have to kind of go charging in there, at the last minute. But serious illness conversations is more about the patient talking about what they want and what they want to know. And then I feel like I had to kind of sit on my hands a bit. But we use a framework called Wish, Worry, Wonder. And that really works, I think, so I wish that I had better news to give you around your disease or your disease progression, just say. I worry that if we spend all your time doing tests, and this goes back to the Being Mortal book, right? Sending people for tests and doing all these chemotherapies and all these treatments and things like that, or, putting in a pacemaker or a defibrillator or many doctor's appointments and things like that, blood work. And I wonder if we spent the precious time that you have left on the things that are the most important to you, if that wouldn't actually be better. So it's not saying you have 6 months to live, right? It's saying it's just, again, language and having those conversations and making it more about the patient and the family and the caregiver, right? So that, I think, is something that really is I hope it's going to change folks. And we're looking at primary care, like, so your family doctor, are they able to have that conversation? Or that nurse that maybe is in the emergency department or maybe on the medicine floor or the oncology ward, are they able to sort of say those things? Palliative care too, right, is I think also we need to know what the patients and families want and expect.
Yeah, you touched on something that resonated with me, though. The primary care physician should be central in this. And unfortunately, what has happened traditionally in the cancer system, now Cancer Care Ontario in this province has tried to change it, but I think we still have a good way to go, is that family doctors would refer to a cancer patient in the cancer center, then the cancer center does its thing, but basically takes over, even sometimes taking over the non-cancer related illnesses and prescribing the antihypertensives and other things, and leaves the family doctor out. Yes, the family doctor gets a note from the cancer center,
Right.
but he doesn't have the same sense of engagement. And then at some point, when the cancer center can do no more, it's almost like they're passed back to the primary care physicians and left out of the whole process. And now you look after the sort of death and dying piece.
Right.
And it must be extraordinarily hard as a family doctor to be thrust into that when you've been left out of the trajectory leading up to it, because you could have had those kinds of wish conversations, worry conversations, etc., that would make it easier to have a final kind of conversation with the patient.
Yeah, that's very much, I think, people's experience, right? Is that they're going full tilt at the cancer center, and then that primary care physician does feel a bit left out, and then they're sort of, now I have to be doing the palliative care of this patient, and that's not my expertise either, because I'm doing diabetes care and new baby care and all. Like primary care has got a big plate, right? They have a huge big plate.
Yes,
but
indeed.
Also, I went to a conference, the Ontario Long-Term Care Clinician Conference, and they had done another study, again, around people working satisfaction with stuff. So if a primary care physician or any physician can have that conversation, everyone thinks, oh my gosh, that's going to be so depressing and I'm not skilled at it and those kinds of things. But again, their job satisfaction actually goes up, right? So they felt like they did a good job. They were able to wrap that care around their patient, even if it's a referral to the cancer center or they have a palliative care team. If they're still involved a bit and they have some skill around those conversations, it's a better experience for the patient and the practitioner. So I think that's really important too, is that, I don't want to do palliative care. I don't want to, there's a team that does that or whatever. But if we can incorporate that into our practice, and again, serious illness conversations can help people have more of it's actually, they can go step by step, like a framework on a card, which I'm like, this seems like it doesn't seem very natural or organic. But I think once you get it down, it really can make a difference to the patient.
No, I'm first hearing about critical illness conversations today, so either I'm really a dinosaur or there are maybe a lot of people who have not had the experience or learnings about critical illness conversations. So for any physicians listening, be they specialists or primary care physicians, how would they go about learning about how to do this and develop this skill?
So right now, we offer education from different places. So it's created and developed. So there's my partners in Waterloo, Wellington that do some education. There's our team in the Southwest through St. Joe's that does some education. But Pallium Canada, if anyone's ever heard of Pallium Canada, so they have a really good online free module called Taking Ownership. And they actually purchased the serious illness conversations from BC, and that there are courses online that you can take them. And that's where, again, you get invited into like a coaching session. And they're not high cost. And it's something where, so physicians can do that. So if you look at Pallium, I think it's www.pallium.ca. Pallium covers all across Canada. And my conflict of interest might be is that I do teach for them. I'm a facilitator for some of their courses. I'm not here to necessarily promote that. I have lots of courses I could talk about and lots of different things. But yeah, that's something that could help physicians that are listening. That serious illness conversation guide is there. You can download it and you can take a course online. And I think you get main pro credits, physicians. So I think that's important.
Yeah, that's important for physicians to get their credits. So there you go.
But that taking ownership module, anyone can do it, really. Mm-hmm. So to kind of understand, what does a palliative approach look like? And it's about a 45-minute online module with an online facilitator. And you just have to register, and then it pops back. Yep, Debbie just did it.
So that's very useful information for people to know. Now, we talked about maybe the primary care physicians left out of things. The other key person that's left out is the caregiver, whoever
Right.
that is, whether
Yeah.
it's a spouse or a friend or a neighbor or whatever, who's very close in providing a lot of the care. And how do they get included? How could they be included more effectively, I should say, into supporting palliative care measures for a loved one?
When I look at teaching folks, we look at something called the domains of illness and bereavement, and it's different boxes around, and patient and family are at the center, and caregiver actually should be in there too, I think. And we look at, their disease management, their physical symptoms, loss and grief, end of life. There's a different categories we look at. I think that, unfortunately, the pandemic, right, had sidelined some of the things that we were doing in groups, right? So different communities were looking. So we had that wonderful Compassionate Hamilton event, and I think stay tuned because more of that will be coming. And I know Cancer Assistance Program is linked into that for sure. So there'll be some promotion or things like that coming. I just don't know what it looks like because they're evaluating it right now. And I know they want to run more events to bring people to say, I didn't even know about this, and I didn't know about this service. Sometimes the community hospices, so the hospices have different programming pieces. So the Kemp Care Network grief and bereavement pieces there. Wellwood has programs for kids after school and teach them how to cook a meal and helps them with their homework. And that in itself helps sometimes you've got kids that are cast into that caregiver role. You look at, for grief and bereavement, Bereaved Families of Ontario has some really wonderful opportunities also for bereave and grief, so that's a little bit different, but you've got that support. And there's caregiver programs all over Ontario. So Hospice Palliative Care Ontario website has a volunteer training program and a caregiver support program that you work through modules, and it's online and it's free. There's a publication called The Caregiver's Guide. I have it digitally somewhere here, but you can download it for free, and it gives you tips and things about how maybe to feed somebody or turn somebody in bed or change the sheets with somebody in a bed. And the hospices and I had talked about doing education like that, almost like a lab, where you would have, a hospital bed and sort of like a mock-up kind of room, and how would I care for someone who's bedridden? How would I feed them? How could I position them safely? Things like that.
It sounds so simple in one respect, but it's not.
It's not, right? Sort of because there's an appetite for that, for those skills, right? And then we teach caregivers all the time. I think that's, if you look at home care, right, we're often looking at teaching folks how to do things, care for themselves, still needing that oversight and of people coming in to see them, but can we teach them some of the stuff to do themselves? Injections and different kinds of things. Or sometimes folks are going into the nursing care centers, right? Because again, home care and health care right now is sort of at a health care. Human resources are not very high, right? We're experiencing low numbers of people in the human resources department. So yeah, there's lots of online resources, I think. And then I think it's also hard sometimes to reach out. So I can definitely give you a list of different kinds of caregiver resources. And again, we've got, Hope for the Best, Plan for the Rest, and there's events coming for that. There's some really great caregiver education in the Champlain area that I know they're doing for free. And there's also caregiver education in the Windsor area, a really good program. I can give you links to those kinds of things as well to share.
And get some of that and put it up on the Cancer Assistance Program website, because that could be useful then to listeners who are outside of the immediate Hamilton area who might want to tap into it. And may as well do shameless promotion of the book, Hope for the Best, Plan for the Rest by Samantha Winemaker and Sien Sao. There was a podcast we've done previously where we talked about the book and how it's laid out and the benefits of planning in the face of a serious illness. That I understand that book is available globally, so if you're in Australia, you may be able to find it in your local bookstore. I can hope so anyway. If not, you can find it on Amazon, so you can find everything on Amazon. It's one of the things that cancer patients fear, I think, the most, besides dying per se, is pain.
Mm-hmm.
And then relatives get involved because as pain medication is given, it often leads to people being obtunded, and hence they look like they're not with us. And so you can't leave them like that. And you get in an oscillation. Can you just talk to me how you would talk to a patient and a caregiver about taking narcotics for a serious amount of pain that you needed to control?
I think that this is a loaded question, to be honest, but that's okay. And I've had experience sort of working with this with people. I think that we also, society today, unfortunately, we have an opioid crisis, right? So that when folks are prescribed a medication to help with pain, it's for a reason. But then they're also sort of given all of this information or an naloxone kit in case they overdose. And I think that's a public safety issue more than anything. And I get why we have to do that. I totally understand that. But I think I've spent years like talking to people about their pain, and from my experience, even working bedside in a hospice when people were at end of life, we used very small doses of medication. We did very good assessment. We made sure they had a breakthrough medication. So we gave them their regular medication, and then we gave them their breakthrough. Again, back to sort of that Dame Cicely Saunders idea, like taking it regularly, not saving it for when you really need it. Dying itself isn't really painful, the actual dying process, but because we have cancer or because we have diabetes or we had a stroke or, we have different kinds of issues, that's what causes the pain. And so that we want to treat that pain and we want to get on top of it so we don't have people in horrific pain. Again, TV, movies, right? That sort of idea. Mm-hmm. And I would say pain is also not just maybe with, you said narcotic or opioid. Sometimes we have to treat pain differently too by looking at the whole picture, like total pain, emotional pain. I'm always looking at people's mattresses, right, to make sure they're comfortable. Is their bed okay? Is their wheelchair okay? Like, how are they sitting? How are they positioned? If they're still getting up, things like that. So what else can we do for pain, right? Distraction, music therapy, art therapy, all those kinds of things are kind of out there. But I think people, yes, they're worried about being in pain, and that if we know that up front and if people trust us a bit, but there's lots of people that don't. I guess there's lots of rules on pain medication, but also, too, don't be afraid to take it, right? Also, our pain medication helps with breathlessness. And I think for many years, you and I probably worked around at the same time. We used to give sleeping pills at bedtime. People would fall out of bed, and we used to give that pill, Ativan is what I'm talking about, when people were anxious or breathless. But really, our morphine or hydromorphone is a better medication for that. And so, and if we, again, start earlier, we're looking at the whole picture holistically. Maybe there's some like psychological pain that we can treat that will make that physical pain less. Yeah, that's what I think. I could talk about pain to you all day.
That was a very good answer to my loaded question.
Okay.
I really wasn't trying to load the
No,
question.
it's okay. It's okay.
Well, I think we're going to wrap up in a moment, but I want to give you a chance, thinking about people listening out there, what maybe 2 or 3 key messages you'd like them to take out of our conversation today?
I would say don't be afraid to ask questions. I find that people sometimes feel like the doctor or even the nurse or the nurse practitioner is the authority, and we don't know everything. And we need to spend more time, I think, asking people questions about less clinical questions and more about what's really important to them. I think that's really important. I think the question you can ask any healthcare provider when you have a serious illness or a life-limiting illness, because I know from fact sheets, over about 70% of people don't ask the questions. Where am I in my journey? Or where is my loved one in the journey? Are we and this is borrowed from Sammy and Cien, beginning, middle, or end? And so am I more towards the middle? Am I more towards the end? I think it's almost like no one's really offended by that because it's like a childhood story, right? If you think about like Jack and the Beanstalk or Little Red Riding Hood, beginning, middle, end of the story. And I think that also healthcare providers can answer that question, right? I think you're more towards the middle. I think you're more towards the beginning. So I think that's a really good way. I use, like I said, language matters, and that's really important. And I just think that if you get referred to a palliative care team, don't be afraid of those people. We're usually pretty nice. We're there for a reason, I think, and that most of the folks that I've worked with or taught they have a story. We all have a story, right? And so that's where the compassion and the empathy comes in for the most part. Again, we pick that specialty over, say, emergency medicine or or labor and delivery. You wouldn't catch me dead working in like a department like that. It was too frightening for me. And when I was in school, that kind of thing. So don't be afraid, don't be scared, and ask questions. It's not, we don't know everything, and we don't know you. You know you, and you know your family. Don't be afraid to ask the questions to us.
I think that's a very good last point to end with, because it applies not only to a palliative care situation, it's about the whole of your illness, about every aspect of it. Don't be hesitant to ask questions. And maybe to add a corollary to it is have someone with you who's another set of ears and maybe has a pencil in hand and can write down the answers, because oftentimes when you're receiving information in the context of a cancer center, there's a bit of an emotional overload, and you may not hear all the answer, you may not hear it as cleanly and accurately as it was intended. So that might just be another little thing to think about. As we wind up today's podcast, I'd really like to remind our listeners that they can listen to a lot of previous podcasts by visiting the Cancer Assistance Program's website, which is cancerassist, one word, .ca. I think there are about 50 podcasts there now that cover a wide range of topics, a lot of different tumor types, how they're treated, but as well a lot of the supportive care services that are really an important and integral part of good quality cancer care. We're blessed to have a lot of them in the Hamilton area. I hope in the area where you live and receive care that you have similar high quality supportive care services. I'd just like to thank Melissa Chadwick for all your insights into palliative care today. You've been a great person to have a conversation with, and I think our listeners will have derived a lot of benefit from what you've said. So thank you very much.
Thank you.
Thank you for listening to the Cancer Assist podcast. Find more episodes, resources, and information at cancerassist.ca, or follow the Cancer Assistance Program on Facebook, Twitter, and Instagram. Thanks for listening.